Hello, everyone, and welcome to today's webinar as part of the Public Health webinar series on blood disorders. This webinar is presented by the Division of Blood Disorders at the U.S. Centers for Disease Control and Prevention, also known as the CDC. I'm Dr. Karen Abe, the Chief of the Epidemiology and Surveillance Branch in the Division of Blood Disorders at CDC. I also serve in the U.S. Public Health Service. I am delighted to join you today to moderate this webinar on the topic of surveillance for venous thromboembolism, also called VTE. Joining me today are two investigators with specialized expertise in VTE surveillance. First, I'd like to introduce Dr. Aaron Windabeau, who is the Edward E. and Helen T. Bartlett Chair in Public Health. He is also professor in the Department of Biostatistics and Epidemiology at the University of Oklahoma Health Sciences Center. He was a co-principal investigator of a CDC-funded project to establish a pilot surveillance system for VTE using both active and passive surveillance in Oklahoma. Next, I'd like to introduce Dr. Tom Ortel, who is Chief of the Division of Hematology and also Professor of Medicine and Pathology at Duke University School of Medicine. Dr. Ortel is a member of the Duke Cancer Institute. He also was a principal investigator of a CDC-funded project to establish a pilot VTE surveillance system in North Carolina using active surveillance. Before we begin, I'd like to go over a few points for joining this webinar. When you join the webinar, you will see two audio options. You can opt to listen via the speakers on your computer or by using your phone to call in. All audio will be muted. At the end of the presentation, there will be time for questions. To submit a written question, please use the questions area of your toolbar. We will respond to as many questions as time allows. Today's webinar will last approximately 1 hour. Please note that this webinar is being recorded. We will begin with two brief audience polls. First, we are interested in knowing more about you. Please select your response to the poll question now. Which of the following statement best describes you? Please select one. Healthcare provider, public health professional, person with DVT, PE, or family member, community-based organization, industry partner. Here's some of the poll results. We have 49% of the audience are healthcare providers, 28% public health professionals. Then we have 5% persons with DVT or PE or a family member, 4% community-based organization, and 15% industry partners. And now we will go to our second poll. What region of the world are you from? Please select one. North America, South America, Europe or Russia, Asia or Africa, Australia or New Zealand. Go ahead and please make your selection. So we have 85% from North America, 1% from South America, 3% from Europe or Russia, 10% Asia or Africa, and 1% from Australia or New Zealand. So well represented internationally. So thank you all for participating in these polls. It's very helpful to learn more about our audience. Let's move to the presentation. Dr. Wendelboe, welcome, and let's begin.
Thank you so much, Dr. Abe. It's a real pleasure to be with everybody, and thank you for your interest in hearing more about surveillance for venous thromboembolism. We'll talk about both novel and traditional approaches, and it's a real pleasure to co-present this with Dr. Ortel. So first, I'd like to begin just by introducing the public health importance of VTE, a little bit about traditional surveillance for VTE, and then I'll go into some of the specific characteristics of Oklahoma's VTE surveillance system. What is VTE? Blood clots that form in the deep veins or the pulmonary arteries comprise venous thromboembolism or VTE. It's life-threatening, and it can also be a recurring event. So patients who have experienced one can still be quite nervous about it happening again. But another very important aspect of it that relates to surveillance is that VTE is preventable. And we've learned quite a bit about it. One aspect is to really look at the risk factors. And there's quite a few of them, and there's a wide range. And you can see that based on what type of risk factors a patient has, we can classify them as being persistent provoked, transient provoked, or unprovoked. And just to give you an example like age, that would be actually, even though it's a well-known risk factor, that's categorized in the unprovoked section, whereas something like cancer is a persistent provoked, and surgery would be more of a transient provoked risk factor. Another factor is anticoagulation. There's been so much development and advancement in clinicians' ability to anticoagulate patients that we really want to see the impact that these, for example, the direct oral anticoagulants have had on both the incidence of primary events as well as recurrence. And then finally, another really important aspect is that VTE is a common healthcare associated event. So I'll speak a little bit more about that now. Pulmonary embolism is actually the most common preventable cause of death in the hospital. And because of this, it deserves a lot of attention as a healthcare associated event, and what can we do to prevent these events and also save lives. And one of the really important aspects of this is that there are some risk assessment models that are standardized where a clinician within a minute or so can assess a patient's risk for both bleeding and forming a clot. And so then based on that risk, the clinician can decide whether to anticoagulate that patient or not. But it's important to realize that while the patient is in the hospital, that risk can change depending on what's happened. And so that risk assessment actually needs to happen probably on a daily basis. Another aspect of hospital-associated VTE that's important is that there are financial penalties to the facilities if you have too many. It can impact hospitals in two ways, both their value-based purchasing score, which is up to 2% of a hospital's total DRG reimbursement payment is at risk, but then also through Medicare's hospital-acquired condition reduction program, those hospitals that are in that top 75th percentile of having excess VTEs can lose 1% of every dollar that Medicare pays to the hospital. And that may not sound like a lot, but it adds up to millions of dollars. So many of us know that surveillance really creates the foundation for a lot of what we know about a condition, and that's the same for VTE. It really establishes that baseline so that we understand what the disease incidence is, and then not only just in a population, but we can learn more about those demographic factors and the risk factors that I introduced earlier. And just a recent example where some of the surveillance came in really handy is with COVID. We saw that with the introduction of some of the vector-based COVID-19 vaccines, they were alleged to cause an increase in cerebral venous sinus thrombosis. And so to really be able to answer that question, is there a risk? You would need to know what the baseline rate of CVST is in your population. And so sometimes, we can be doing surveillance for a condition like VTE and not even anticipate all the benefits that come along later on, like this particular aspect. So on more specifically to disease surveillance for VTE, and in fact, the system we set up here in Oklahoma, as Dr. Abe said, this was a fantastic collaboration between the U.S. Centers for Disease Control and Prevention, Duke University, and the University of Oklahoma Health Sciences Center. And in a way, it's hard to believe that this collaboration started a decade ago, and we met together to really figure out what our case definitions should be, the data collection form, and so that we would be able to compare the results of our surveillance systems. And so this active surveillance that we did started in 2012, and we did that for 2 years. So we really focused on Oklahoma County, one of 77 counties here in Oklahoma, but it's a urban county, and we have 14 tertiary inpatient facilities as well as 7 outpatient clinics that had a large enough volume of imaging, either compression ultrasound or say like radiology, chest CT, that we did surveillance to find those patients. One really helpful aspect was that the health commissioner made VTE a mandatory reportable condition, but then he delegated the authority to us at the University of Oklahoma to do that surveillance. And so it really didn't increase the burden on the healthcare providers too much. It just really created that framework that we were able to get access to the data, and essentially facilities weren't able to say, we don't want to participate in your study because this is public health surveillance rather than research. And then there was, for our active surveillance, there were 2 important steps. The first step was to identify the patients, and that was to use essentially the gold standard method of identifying a VTE case, which is from imaging reports, compression ultrasounds for deep vein thrombosis, or chest CT, or MRI, VQ scans for PE. And then once we identified those patients, then the next step was the surveillance officers would access the patient's medical record and abstract the information that we had predefined in that data collection form, again, like demographics, risk factors, and whatnot. So just to give you a brief overview of the geography, here's Oklahoma, and Oklahoma County is essentially dead center right there in the state. This was a strong aspect for us just because most of the counties around Oklahoma County are relatively rural, and so we didn't have necessarily too much of a problem of patients that lived in Oklahoma County going to another county for care. I'm not saying that it didn't happen at all. I'm sure that it did, but it wasn't given the market we have here, that wasn't a major consideration. And then as we zoom into Oklahoma County, this just lists the 14 healthcare facilities, the inpatient facilities, the blue dots. And then as we look at the outpatient facilities, my apologies, these are kind of hard to see, but these are the 7 outpatient facilities in the county that were part of our surveillance. So briefly, I'd just like to review some of the findings from that first round of surveillance, and I listed the citation there so you can access full findings later on if you're interested. But the overall age-adjusted incidence rate of VTE in Oklahoma County during this time was 2.47 cases per 1,000 per year. And but then one aspect of this that was really interesting is, as I mentioned, age is a known risk factor. And so as we look at those people that are 18 years and older, that incidence rate was 3.02 per 1,000. And then as we just look at these age groups, you can see how for those different age groups, the incidence rate really increases for each group. This is a brief summary of what we saw as far as recurrent events, the cumulative incidence, and we stratified it by those provoking risk factors we talked about earlier. The persistent provoked up here, the transient provoked here, and the unprovoked. And so you can see that in that first couple weeks, is where this steepest risk of having a recurrent event is, but as time goes on, those with persistent risk factors are going to have a higher risk of having a recurrent event, followed by those with transient risk factors, follow those that are classified as unprovoked. And so again, this is very interesting for us to learn how can we prevent some of these recurrent events. And then finally, wanted to share just briefly the distribution of some of those risk factors, again here at the bottom of the table, lumping them into the persistent, transient, and then unprovoked. But then, and you'll see that we are really highlighting hospitalization, that 36.2% of our patients essentially had a hospital-associated VTE, just to put that in perspective of, again, the part of the reason why we want to do surveillance, and one of the areas where we're trying to reduce the burden of disease. Of course, there's limitations to surveillance, and particularly active surveillance. So this active surveillance that we conducted was really intensive in our need for the surveillance officers. I mean, just thousands of hours of surveillance officers to read those reports and then to collect that information, really making us think about, are there ways that we can automate this surveillance? And then, of course, we would be concerned about the accuracy of data in the medical charts. Sometimes that data may not even be there. And then also just recognizing that, you know, when you've got 14 inpatient facilities, there's going to be heterogeneity in their electronic medical record system, and then that even extended to outpatient facilities with the quality of the imaging technology that they had, and whether they contracted out the reading of these reports. So anyway, there was some heterogeneity, but we of course tried to standardize this surveillance as much as possible. And so with that, I'd like to turn the time over to Dr. Ortel to describe a few aspects of their surveillance system.
Thank you, Aaron. I'd also like to thank Dr. Abe for inviting us to talk about our system. I'm going to briefly give you an overview of how we set ours up in Durham County, which is located also about smack dab in the center of North Carolina, and how it differed a little bit, but then go into at least the first introduction of a mechanism that we hope actually can make some of this a little bit easier and decrease personnel burden. So as you can see, Durham County is located right in the center. Within Durham County, there are 3 hospitals. Duke and Duke Regional both share the same electronic medical record and can be probed from anywhere, and are the 2 red stars. The Durham VA is located across the street from Duke, and that is the green star. In case you're a basketball fan or just wondering, University of North Carolina is somewhere down over here. And then to the east of us is Wake County, which is, I think, the fastest growing county in the United States right now with people moving in. So population in Durham County at the time we started was 280,000. Racial distribution was 52% white, 37% black, and 4% Asian. Now, the way that we set ours up was at the Duke system, there is a decision support repository, which is basically updated every night. And that includes essentially the EMR from all of the hospitals, all of the clinics, et cetera, being consolidated into one data repository. This includes diagnostic information, treatment information, it includes billing information, it includes everything. At the VA, we used Vista, obviously, which is the Veterans Information Systems and Technology Architecture, their EMR. The only thing that was not searchable at Duke is autopsy data, which was scanned in as PDF files, so you couldn't read those with our search engine. Now, our primary search strategy was something called Deduce, or the Duke Enterprise Data Unified Content Explorer, and that's basically a portal-based system that you can use to search for billing, you can use to search for ICD codes, you can use to search for CPT codes, etc. And working with the folks at CDC and folks at Oklahoma, we came up with the list of all the ICD-9 codes, which we were using at the time, and the CPT codes that we were going to search. At the VA, we could not use the same system. Basically, the Vista program was searched, all radiology imaging was pulled up, and that's what was searched. All of the results had to be manually reviewed, confirmed, and cross-matched in order to avoid duplicate entries. What we found was the overall incidence in Durham County was 1.44 per 1,000. And we also noted the increased risk in African Americans. It was 1.98 per 1,000 versus whites, 1.27 per 1,000. Just a little below 20% of the individuals had a prior VTE. The time of occurrence of that prior VTE on average was about 4 years before current diagnosis. And for hospital-associated VTE, again, a primary focus of ours for this prevention strategy or surveillance strategy, we had 16.9% of the patients who were diagnosed while they were in the hospital. They had been in the hospital for 2 days. On average, the median time to diagnosis of VTE was 11 days. In addition, VTE was diagnosed in the outpatient setting within 90 days of discharge from the hospital in an additional 27.5%. So 45% of our folks actually have some kind of hospital-associated event. What we also were interested in was how could we apply this? How could we use it to monitor things forward? We, again, wanted to look at treatment. Most folks were treated with anticoagulant therapy. 7% did receive an IVC filter. Very few received thrombolytic strategies. But interestingly, by following these people forward, we knew that up to 1 year later, half of the people were still on an anticoagulant. And outcomes, 28.5% had died by 1 year, and we had 103 recurrent VTE. Now, as with the program at Oklahoma, ours was also very intensely heavy for personnel requirements, people having to review all of the records. We were limited by accuracy of the data. For example, an ICD-9 code of PE being used in order to order the testing needed and then find out that it was negative. So you still had to go through each one and confirm it. Patients were seen at more than one institution. For example, all of the patients that we diagnosed at the VA, 10% of them were also separately diagnosed at Duke. And also, obviously, there's the potential that we could have lost patients to University of North Carolina to the west or Wake County to the east. So how do we get around this? One of the things that we were very interested in exploring was the use of machine learning strategies or natural language processing to try to decrease the need for personnel. This computer-based approach converts electronic text entries into a structured, semantically interpretable form for further analysis. And these methods have been used successfully for time and labor-saving alternatives to manual extraction of data from EMRs to identify patients with specific medical conditions. What we looked at was we had now our body of patient data or imaging data. We wanted to see if a particular program actually could pull out those positive results. And IdealX is a software product that enables users to extract desired information from unstructured text. It takes the radiology reports and essentially reads them to identify people who had a VTE. It was developed at a single institution, an orthopedic hospital, over a 5-year period, evaluated diagnosis of DVT or PE. You can see here with the reference below, sensitivity of 97.2%, specificity of 99.3%. How did it work when we applied it to our data? So what we did was we took our positive results. We also had obviously all the negative results at the same time. We could then combine these records and use the model that was developed in the paper. Again, remembering this was for orthopedic patients only, and now we're looking at the breadth of everything. And then compare them to manual records. This is what we found. Basically, from almost 1,600 imaging reports from Duke and 1,500 reports from Oklahoma, accuracy was a little bit lower, 93.7% overall, 92.4 at Duke and 95.2 at Oklahoma. Sensitivity was a little better at Duke, specificity was a little better at Oklahoma. So that gave us a little bit differences in the positive predictive value and negative predictive value. Now, what were the issues that came up? So for example, here's the false positive results. We had 104 false positive results at Duke. Importantly, almost a third of our VQ scans were incorrectly interpreted because of the way that people dictate their interpretations of VQ scans as opposed to a CT angiogram. They don't say there's something in a pulmonary artery, they say that there's a filling defect or there's a defect that they see. Other problems include superficial thrombophlebitis, chronic or residual DVT, and then indeterminate reports. For false negative reports, there's this inclusion of questionable cases as whether or not they're positive and negative results in the same report. For example, saying there was no DVT in the left leg, but there was a DVT in the right leg. How is that interpreted? Unrecognized text or symbols, etc. So this was our first venture into machine learning. What I'd like to do is turn it back over to Dr. Windabeau to then say, what are the next steps as we go forward?
Thank you so much, Dr. Ortel. Yes, and maybe I'll just mention that reiterating this need for the personnel requirements, it might take a minute or so for a surveillance officer to read an imaging report. And so just in that study that Dr. Ortel just talked about, that was like approximately 3,000 records. So that's 3,000 minutes. And then IDLX could have read all of those within a second or so. And so just to give you an idea of how interesting that is. I'm sorry, I need help getting back to the slides. All right, so as you have listened to Dr. Ortel and I, you may be thinking, can we do surveillance in our facility, and can we implement this natural language processing, given that it looks like there's a lot of promise, and there is. But there are a few considerations we want to talk through because they're really going to affect the results. And this is ongoing work, but it's pretty exciting, so we wanted to share it with you all. So the question is, what's the ideal source of records for surveillance? Again, we've talked again about radiology and cardiology for the compression ultrasounds, the chest CTs, but do you get everything from radiology, everything from cardiology, or are you going to select records that meet a priori inclusion criteria? Well, and just thinking about how would we define those a priori criteria, so there's the different imaging reports, as you see here, chest CT, MRI, VQ, compression ultrasound, and then to identify those, oftentimes we use codes, CPT codes, or ICD-10 procedure codes, but then sometimes these procedures have a text description. And some of you may have heard that a rule of thumb, CPT codes are used in outpatient and ICD-10 are used in inpatient. From the surveillance that we did, we found that that was not really true at all. We saw a lot of these codes being used in all facilities, so it's really important to be thinking about both of those. And then we found quite a source of our data where they didn't have any codes at all, they just had that text description. And so how are those distributed? Well, as we looked, and this goes back to that first round of active surveillance between Duke and us and CDC, we had identified a priori 44 unique CPT codes, 118 unique ICD-10 codes as a case definition. But as we went through this next round, we wanted to use that same case definition. But like I said, when we requested the data from the OU Medical Center, we actually got everything from radiology and cardiology, the non-invasive vascular lab, and we found that there were 454 unique radiology scan types, and so we needed to read through those, and we identified that about 85 of those seemed to align with those codes, those predetermined codes that we listed above. Same thing with the non-invasive vascular. We saw 56 unique text types, and we identified 34 of those that aligned with the word. So we thought, well, hopefully there'll be a really great match between here. Well, the other question then is, you say, well, why don't, if IDLX can read all of these so quickly, why not just have IDLX read all the records? Why does a case definition matter? Well, of course, many of us know that the prevalence of the condition is going to affect your positive and negative predictive value, right? And so as we were looking at those results that Dr. Ortel just shared with you, we had this option of using a highly specific inclusion criteria. And of course, there's benefit in that because of the reliability of the cases, but then the prevalence is going to be the lowest, by definition, when you use a very specific case definition. And we found that the positive predictive value of that NLP of IDLX would suffer once the prevalence got below 30%. Of course, on the other hand, your negative predictive value is really high when your prevalence is low. And then we looked at using a highly sensitive inclusion criteria, And that, of course, includes the highest prevalence of records, but then you have the chance of having these false positives. And so still quite a lot of work, but at the end of the day, I can just tell you that it is very important to still a priori select your records and not just have your NLP look at everything because because of this prevalence issue. But one question you may want to ask yourselves is, what's the impact of missing cases in your VTE surveillance system? Here at Oklahoma, we've been really focused more on a sensitive case definition. We don't want to miss any cases right now because as we're trying to figure out really what's the best way to do some of this surveillance, it's interesting just to see where some cases are coming from, and we didn't want to, miss some just because we went to a specific case definition too soon. You may remember that when I was talking about surveillance, that it's a two-step process, right? The first step is to read the imaging report, and then the second step was to collect the information on those cases. So even after we automate that first step of using the NLP tool, then the question is, can we automate that second step? Can we use computer programming to pull the information from the EMR and put it into the surveillance database? And as we had thought about what kind of data needed to be collected, there's the demographic characteristics, there's those risk factors, again, so that we can categorize them as persistent provoked, transient provoked, unprovoked. We want to know about anticoagulation, and this can get really complicated because there's prophylactic doses, there's treatment doses. We need to be able to collect information to determine if there's disease recurrence. We've talked about that already, right? And so in developing our data collection form, again, going back to 2012 to 2014, we had 268 different fields in our data collection form, and we wanted to see, how many of those could we automate. It looks like about half of them we can automate right now. About 40% have unknown feasibility, and about 7.5% we hope to be able to do that in the future. But anyway, again, this is ongoing work, but it's I guess to summarize is it's quite challenging to figure out how to pull the information from an EMR in a standardized way and make sure that it's accurate. And so there really is a lot of promise, but there's still some challenges. And with that, I'd like to turn it back over to Dr. Ortel to elaborate on some of those next steps.
Thank you very much, Aaron. Okay, so let's talk a little bit about how we're thinking about moving this forward, because we're very interested in this. This is a very exciting opportunity to begin to actually track venous thromboembolism in the US. So the next steps. If you don't have to make it from scratch, if you can use something that's already there as your model or something that you're going to build on, the latter way is much easier. And so one of the things we're very interested in is the National Healthcare Safety Network. Now, this is the nation's most widely used tracking system for healthcare-associated infections, or HAI. It serves more than 25,000 medical facilities nationwide through the CDC. The NHSN data are analyzed by the CDC and others, and it's providing insights for HAI prevention. Furthermore, local, state, and national trends can be used to identify emerging problems and areas of concern that need intervention, and to measure progress in HAI reduction against national, state, and local prevention goals. You can begin to see how we could put venous thromboembolism in here in each step along the way. And if we had a national surveillance program available at the time, we could have tracked changes with the pandemic or with other things going on across the country. So NHSN is interested in developing a protocol for VTE surveillance. Again, something that now is very attractive. A key component of this protocol would incorporate an automated NLP, or natural language processing strategy, to consolidate information extracted from unstructured free text reports to determine VTE diagnostic events. So you do that at your facility. And then the NHSN is working with the CDC's Division of Blood Disorders to adapt a rule-based natural language processing tool developed at CDC to identify patients who meet VTE diagnostic criteria. So we're moving away from IdealX to a product that actually would be through the CDC that could be basically implemented in your institution, would be the goal. So current protocol, what we're working on at Duke, what Dr. Windabeau is working on at Oklahoma, are working with the CDC is to create a master data set containing imaging reports for suspected VTE between the 1st of January 2012, right when our VTE surveillance project began initially, the first phase, and then running up through 31 December 2020. We basically are going to create 3 different unique data sets out of this. There's going to be a development data set, and we're going to build it for each imaging subtype. It's going to be enriched to include 50% of the encounters with a positive diagnosis versus negative diagnosis, so we have a mechanism to ensure that we develop this properly. The testing data set for each imaging type is also going to be enriched to include the 50% of the encounters with positive VTE diagnosis. And here we can go back and tweak things if we start pulling out too much superficial thrombophlebitis, or we pull out other diagnoses that we're not necessarily wanting to capture. Then the evaluation data set is the third one. This is the most important one, and would consist of consecutive imaging records to mimic a real-world setting without enrichment. So now you're putting in basically the reports from all the CT angiograms, all the ultrasounds, etc., over a period of time, so that you can see, can I still pull out all the positives without getting caught up with all the noise of all the inappropriately ordered tests or the tests that are negative. And then this is all going to be compared to how did we, as manual reviewers, finally categorize each of the diagnoses that we've seen. So this is how we're going to be building this or taking these to the next steps, so that we're able to at least implement the natural language processing strategy and machine learning into that initial part of the surveillance part, to just get the VTE records out. Now, what issues are going to have to be dealt with this? If you really wanted to have a nationwide surveillance program, you're going to have institution-specific issues, system-specific issues, and national level issues. For institutions, an EMR, if you've seen one EMR at one hospital, you've seen one EMR, and that's about it. I mean, Epic is at a lot of places, but Epic is also adapted to individual hospitals and changed, so it's not identical from institution to institution. You also have to be able to make sure that you're able to cover these different diagnostic imaging modalities, where ventilation perfusion scan may be used preferentially or not, or MRI might be used more preferentially. For systems, here the attraction is the ability to get your data for your entire network, but also get it for your individual institutions. As Dr. Wendelboe described, they have multiple hospitals and multiple outpatient areas. It'd be nice to be able to have the aggregate data, but also everything broken down into the individual locales so that you can identify problem areas. And then nationwide, we have to make sure that we're able to uniquely identify individual patients seen at multiple institutions to be all-inclusive, and yet exclude duplicate entries. A lot of patients go to a lot of different places, and they can get caught multiple times. For example, in the data set that I presented, 10% of our people who were diagnosed at the VA were also separately diagnosed at Duke, or picked up at Duke as new diagnoses. So we had to go through and compare each one. But then, what does this actually give us? What is this? How do we build on this? Well, that's what's most exciting to me, is to then be able to not just have a surveillance program for VTE, but also how can we use it? We can interface it with VTE risk assessment tools to confirm use of optimal thromboprophylaxis, correlate outcome events, try to get that hospital-associated VTE rate down, okay? We can use it to monitor the use of imaging studies, to also identify, are there reasons why people are ordering it when they shouldn't order it. Still, at our institution, as I'm sure at most institutions, the majority of CT angiograms that are ordered and ultrasounds that are ordered are negative. We also want to be able to use this as a way to segue into therapeutic management, so that we can make sure that people are being treated appropriately for the correct duration of time. As Dr. Windabeau talked about also, this whole idea of splitting patients out into provoked and unprovoked, who should be treated indefinitely, who should not, follow therapeutic management. We could also track the risk of recurrent VTE and make sure that we know if there are certain conditions in which we should be treating patients differently. And obviously, monitoring for hemorrhagic complications remains an important piece as we consider which anticoagulants should be used for which patients. So, in conclusion, venous thromboembolism continues to present a significant clinical problem, with hospital-associated VTE still representing a significant part of all the events that we see. Natural language processing methods provide a novel approach to perform VTE surveillance and begin to take down this requirement for having personnel your program strongly dependent on having personnel. And then implementing something nationwide, this would really provide some essential infrastructure to promote best practices for VTE prevention, VTE diagnosis, as well as VTE management. I'd like to thank everybody for calling in today and spending an hour with us. I'm going to turn it back over to Dr. Abe, who's going to moderate the question and answer session.
Thank you, Dr. Ortel and Dr. Windabeau. We will now shift to the question and answer section of the webinar. Again, to submit a written question, please use the questions area of your toolbar. So let me go ahead and start. You know, you both found false positives and false negatives when you used the NLP. How confident are you feeling about using IdealX or any NLP when you did find these false positives and false negatives? I mean, how are you going to address, do you really want to automatically measure VTE?
Well, maybe I'll take a first stab, and then Dr. Ortel, if you'd like to also comment. So it's interesting, but I would just say that I'm very encouraged by the use of NLP for a couple reasons. The first one is that the sensitivity and specificity were still quite high, right? And over 90%. And so I think that that's helpful. Another aspect is that if you know what your sensitivity and specificity are, as well as positive and negative predictive values, you can potentially adjust for that as well as you do ongoing surveillance. And so I would just say that you don't want the perfect to be the enemy of the good. The other thing that I'd just like to say, though, is that as we move forward with CDC's product, it's encouraging that CDC staff will be able to continue to improve, identify things that are causing some of those false positives, false negatives, and that's essentially part of the machine learning process as well, is that it'll learn and actually improve.
And I'd like to also follow up on that and just say that keep in mind that the data that we presented with IdealX, this was a program that was first taught and then studied in a system that was very focused. It was in patients who underwent hip and knee replacement surgery, and then they had an ultrasound or a CT because they came back in with symptoms. It was very focused on the population. What Dr. Wendelboe and I did was we then took it and we left it taught the same way, but we dumped in everything. All the warts and pimples and everything went into this thing. And that's where it became obvious that we had to make sure that we cover all of the kinds of imaging modalities that can be used, because ventilation perfusion scans, depending on how somebody interprets it and what text they put into their interpretation, impacts the ability of a program that may have been taught on CT and geography to then read a different modality or search a different modality for the terms that are needed. So that was just a very early first pass. And it's actually been very interesting because we've sat down and analyzed a lot of the errors and where things were misread. And that's where we learned things like if it says there's no PE in the right lung, but there are PEs in the segmental arteries on the left side, depending on which one gets read first and which one gets priority is how it gets read. So you can begin to actually teach program or have it learn how to read the nuances of a lot of the interpretation. Now, there's only so many ways you can say pulmonary embolism and things like that. So we know we've got a certain ground that we're working from. And I guarantee you there will always be some degree of error. But at the same time, I think that we can really get it to the point where it's the vast majority of the time, it's giving you accurate data that you can use.
Thank you. So from your explanation, this goes to another question from the audience. So it's possible to use IDLX or another kind of NLP in other specialties of medicine, such as pathology. It's not that you're speaking only for VTE, but these programs, NLP, can be used for other specialties.
I think that you could adapt this to almost anything. It would be harder to use for really rare things that have a variety of different symptoms associated with them. But we're just looking at adapting a tool to a particular problem.
Right. And really, we started with IDLX, and then now we're moving into working with the folks at NHSN with their NHSN rules. And the lessons that we've learned from IDLX we're bringing into NHSN rules, but it's a different natural language processing. It's rule-based. So, and still there's challenges. So I think with all of these kind of platforms, there's still an adaptation process that needs to take place. One of the questions, so this is, I think it's coming more into, one person asked, telemedicine, how do you incorporate that into surveillance and NLP?
Okay, so there's different ways that you could look at this. So, for example, entrepreneurial radiologists can be located in anywhere, and you could download all your data to them. They could read it, and you'd get your feedback. As Dr. Windabeau stated, some of their sites actually had a centralized reading service. In theory, then, you could actually be a clinician, and you could have a patient who's at the hospital across the county, across the state, or across the country, and you could get this data and actually use it to supervise somebody or manage somebody or make recommendations for managing them. So you could incorporate this kind of data into telemedicine. I'd look at it as more as it might help you understand the kinds of situations that you've got going forward rather than be actively giving you stuff. But there's nothing that says that it couldn't actively give you a diagnosis. It could actively read, and you'd pull that up instead of having a person there looking at the imaging.
Yeah, and if you don't mind me just adding on to that, is that again, we're going back to what we consider a real gold standard method of identifying cases of VTE, and that's from an imaging report. And you know, not every it's not easy just to get a machine to do chest CTs, right? And so when a clinician or a practice or whatnot has one of these, they also need to be registered and licensed, essentially. I may not be using the exact correct terminology, but that's part of the way we identified eligible participating sites, is because they had a licensed equipment to do these imaging reports. And so as far as circling back to then telemedicine, is that certainly patients are going to see their physician via telemedicine, but they aren't going to probably get a gold standard diagnosis via telemedicine. They would still need to go somewhere and have that imaging done.
Thank you. And this just brings up another, you have two separate surveillance systems, one in Durham County and one in Oklahoma County. And then you decided to kind of bring those together for the natural language processing project, but you have differences by by what kind of scans your hospitals had, and that kind of showed up in some of the findings. Can you guys speak to that?
I'll let Dr. Windabeau first this time.
Yeah, it was interesting just because of the distribution of records that we received, and when I don't know how easy it is to go back to any of those slides that show the distribution of false positive results, but you'll see that there was a difference between OUHSC and Duke and those and the reasons for those false positives and false negatives. And I think that's part of the power of doing a multi-site study is we know or at least hypothesize that there's going to be regional differences, that radiologists or clinicians may use different terminology and when they dictate an imaging report. And as you mentioned, I believe the Q scans were more frequent at Duke than they were here in Oklahoma County. And so it's important to use different sites so that we can see the difference that impact the results and the interpretation of the results.
And to build on that, it's kind of like we took a program that had been taught how to read on a single hospital, an orthopedic hospital, and then we applied it to a broader spectrum of things. By having the broader spectrum also, it allowed us to get in some additional of the complexity of what we were turning up here. And this is the slide. I'll let Dr. Windabeau elaborate on any of this if he wanted. Ours did not pick out these other ones. It just misread something as evidence of thrombosis.
Right, and so we just found that this was interesting, that like superficial thrombophlebitis was really our biggest issue here in OUHSC, and it didn't turn out to be an issue for Duke, whereas no evidence for thrombosis essentially was the issue with IDLX and the Duke system, whereas it was not as big of an issue. And so for here at OUHSC, so it's interesting just to go through this process. As you saw, our backgrounds are in public health and medicine, not in computer science. And so to start working with collaborators that are experts in machine learning, AI, NLP, and kind of address these issues is really exciting.
All right, thank you. Here's a deeper in the weeds question. So do you believe that perhaps a collaboration with radiology to adopt the radiologist synoptic reporting with required coded data fields and the branch logic to permit them to identify where a path forward might be, at least for VTE specific studies such as CTPA? I think the question is really getting at, since NLP is reading the radiology reports, how do we see, is moving forward, should we be reaching out to the radiologists? And I think we've had different conversations, because even how each radiologist might read things could come up differently. Not even, it could be per person, per hospital, but is that an area to kind of look into? What are your thoughts on that?
I think it actually might be interesting to, at some point, definitely have the radiology community involved in reviewing this and seeing where we find errors and seeing where we find problems. I think that we can also say that sometimes if you're reading a radiologist's report, depending on how you're reading it, you may wonder exactly what were they trying to say where. And that's one human reading another human's interpretation. So we may actually find things that are not well said or not well, terms not well used, and ultimately lead to more standardization. I don't think we'll ever get to the point where the radiologist will have 3 boxes and it'll be a drop-down list and they'll just kind of think along there. But I do think that we can make sure that we improve the communication between the radiologist and between the medicine person or medical person who's taking care of the patient to make sure that the information is correct, is accurate and interpretable.
And I may just add that we do actually have a radiologist as a co-investigator on one aspect of the project. As I said, since this is ongoing work, there's still just a few more aspects that we want to iron out. So I'll be honest that we haven't involved him much yet. We feel like we needed to clean the data a little bit more and then take it back to him and get his input. But I mean, it is a critical point that we need to have all stakeholders at the table. One other aspect I'll just mention though is that it's been interesting as we've done this surveillance that just relying. So we didn't actively present on this aspect of the surveillance, but we really talked about active surveillance. There's also passive surveillance, which is using ICD codes or whatnot to identify cases of VTE, and we actually did that, and we compared the results from active surveillance to passive and saw that there was some discrepancy. And so I think that this circles back to the question about involving radiology, because we need to really be very clear about what that gold standard method of identifying an incident case is, and being able to differentiate between an incident case and a recurrent case, and understanding that, like in the case of DVT, oftentimes you'll even have a series of follow-ups. And so same argument could be made for bringing in a cardiologist, which we've done.
And I have a couple more questions. So does NLP capture risk factors associated with VTE? And then a follow-up, did NLP perform differently based on patient demographics?
Windabeau, I took the first, I'm alternating with you.
Okay, great. Sorry, Dr. Abe, would you repeat the first question?
The first question is, did the NLP capture risk factors?
Right, and so no, it not really from looking at the imaging report. Those risk factor data and the system as we have used it so far is really in the electronic medical record, and so we're using HL7 and other standards to try and find those risk factors. And then, I'm sorry, what was the second part of the question?
Second one is, did NLP perform differently based on patient demographics?
So we have, at OUHSC, have not looked at that yet. The study that we've done so far was really to just, it was de-identified in terms of the patient characteristics. And but I think it's a really important question as far as follow-up, really understanding some of those differences. But maybe Dr. Ortel, I'd turn it over to you.
I think that what we wanted to demonstrate today was the value of NLP in helping us automate as much as possible the VTE surveillance part of it. But I think once we know that we've got that and we can work with that, then it comes down to, okay, how would you try to use NLP to expand out to these other pieces, if you will, to expand over into looking at identification of risk factors or outcomes for treatment, et cetera. You'd have to build it differently. You'd have to expand it. That's what I'm looking at. Is I think that's the neat thing that would come once you have a VTE surveillance in place. You then want to build on it to then start identifying risk factors, outcomes, et cetera. And the question about different performance in different groups of patients or different locations, et cetera, I think that's also exciting. We just haven't gotten there yet. This is still very early.
All right, well, thank you. I think that ends our Q&A section. So we'd like to thank each one of you for joining us today. We also like to thank our colleagues at the National Blood Clot Alliance for hosting today's webinar. Very shortly, you will receive an email asking for your feedback, so please respond with your comments. If you have additional questions about today's presentation, please contact Cynthia Sayers at csayers@cdc.gov. Today's webinar will be archived and the content will soon be available at CDC's Division of Blood Disorders website as shown on the slide. Thank you for joining us today and have a great afternoon.
Thank you.